Good evening, everyone, and welcome to The Advantage of Prophylaxis for Adults with Joint Issues, part of the National Hemophilia Foundation's Hemophilia webinar series. This series is supported by an educational grant from Novo Nordisk. Our presenters this evening are Dr. Christine Kempton and Jim Munn. Jim is the nurse coordinator at the Hemophilia and Coagulation Disorders Program at Michigan Medicine in Ann Arbor. Michigan Medicine, located at the University of Michigan, supports both patient care and research in a broad range of specialties, including hemophilia. Dr. Kempton is an associate professor of hematology and medical oncology at the Emory University School of Medicine. She is also director at Emory University and Children's Healthcare of Atlanta's Comprehensive Bleeding Disorder Center. Welcome, Dr. Kempton and Jim.
Thank you.
Thanks so much, Kelly.
You're welcome. Our program will conclude with a question and answer segment. To everyone, to ask a question, go to the area in the far lower left of your webinar screen and type your question into the field just to the left of the send button, which is located in the pod or area labeled chat. Click the send button when you have finished typing your question. However, please note that your question will be addressed during the question and answer session at the end of the presentation. There are no handouts for this presentation. However, a recording of this webinar will be available shortly on the National Hemophilia Foundation website, hemophilia.org. And now I would like to turn things over to you, Jim. Please go ahead.
Thanks again, Kelly. And thanks everyone for joining us this evening about the advantage of prophylaxis for adults with joint issues. So before we get started on that topic in general, let's take a look at the risks and consequences of having factor VIII or factor IX deficiency. And we know that the biggest risk of hemophilia is, of course, bleeding, which occurs primarily in joints, muscles, and soft tissues. And the consequences happen as a result of the bleeding into those areas. We will have deterioration of the joint over time. You can be missing school or work days. And then, of course, you become physically inactive during the acute bleeding episode, which over time can take a toll on an individual's psychosocial and emotional well-being. And lastly, of course, the insurance issues always can rear their ugly head. Let's take a look at what happens from X-ray images that we see when bleeding occurs into joints. As you can see here, this is a nice, smooth, contoured joint, knee joint, in which both the femur up here and the tibia down here have beautiful, smooth lines, and there's a wonderful joint space. Essentially, this is the representation of a normal knee. Once bleeding occurs, however, you'll see that the joint space narrows and that we start to get these irregular lines, a little bit of a lytic lesion here, some thinning of the bone. And as that occurs more and more, the end result you see here is essentially bone on bone, which is exhibited with extreme pain and often requires knee replacement at that point. So the long-term effects of multiple bleeds are listed here, and you can see them in the pictures. So for instance, this gentleman has a loss of range of motion in his elbow. That's the extent to which he can extend it fully. Similar to this guy's knee here on the right. And unfortunately, that range of motion will lead to weakness and then atrophy of the muscle. You'll see that the calf is smaller here, and that the upper arm of this individual has lost some of its muscle tone too, so the atrophy occurs. We also then can have some weakness and some impaired sensation of the joints, which makes it difficult sometimes for you to recognize proprioception, which is your ability to identify your body in space as a result of the continued bleeding that can occur into the joints. Stiffness, pain, of course, will occur, and then you have difficulty with function, such as walking, standing up. Sometimes climbing stairs can be difficult, and even to the point in joint elbow bleeding where eating or using your arms can be difficult. So, is there a way to prevent these risks and consequences? We do know that prophylaxis can prevent long-term consequences in hemophilia, and that's been identified in the joint outcome study that was done by Dr. Manko Johnson and her colleagues. And total bleeds and joint bleeds increase as time increases with factor levels below 1%. So you can see in this picture here, the graph to the left shows essentially those patients who are less than 6 years of age. And you'll notice that bleeds occur, increase as the factor level stays below 1% over time. And when you're 10 to 65 years of age, which is this graph here, you'll notice that that's even more enhanced. And in the middle, what we have now is the probability of having no bleeds if your factor level is kept at less than 1%. So over time, in children, you'll see that the probability of no joint bleeds really decreases demonstrably. And in the adults, it's even worse. It starts at a lower probability and continues downward from there. So what are the types of hemophilia treatment that are available for patients with hemophilia A and hemophilia B? Episodic treatment, which is on-demand treatment, is treatment that's given anytime you have a joint bleed or any type of bleeding that occurs. And then we fall into prophylaxis. Continuous prophylaxis, or sometimes called primary prophylaxis, occurs as a regular treatment that's often started before the age of 3 and certainly before a second large joint bleed occurs. Secondary prophylaxis, again, is a regular continuous treatment that started when there's been 2 or more large joint bleeds, but before you have any joint bleed, disease that has occurred. Tertiary prophylaxis is when you've had some joint disease over time and you do continuous treatment to prevent further damage. And lastly, we can have periodic prophylaxis, sometimes called targeted prophylaxis. And that's done just before certain periods of time, such as during and after surgery or before a specific sporting event, season, activity. So, what's included in the prophylaxis consideration? This is something that the patient and the hemophilia treatment center should decide together. And it's not just for kids. So the first thing we always want to do is take a look at what are the bleeding triggers that are going on in the individual. What's their physical activity level like? Do they have already some established joint damage or an inflamed synovium that may be something that is considered in the process of deciding on prophylaxis for the individual? What's the number of acceptable joint bleeds that the individual and the HTC, have decided would be beneficial for the individual over the course of, for instance, a year? And lastly, what's the trough level that we want to keep this individual at in order to manage all of the concerns associated with the other points of the triangle? And this, of course, the frequency of treatment is the biggest concern related to cost with prophylaxis. So what are the benefits of continuous prophylaxis? We know that prophylaxis results in a number of things. Certainly less chronic pain over time. The need for orthopedic surgeries drops off. Patients report an increased health-related quality of life, and they also report less joint bleeds as a result of being on prophylaxis. We know from studies that patients miss fewer school and work days, and that in pediatric patients, they have higher physical health status scores. As far as improved joint health, this was a study called the SpinArt study that was done using prophylaxis in patients after joint disease were present in adults. And what they found was that after a 3-year period of time, the joint health score was improved in the prophylaxis group but worsened in the on-demand group. And that there was a correlation that fewer bleeds led to a greater improvement in the individual. We also have a study that was recently done by Dr. Manko Johnson looking at some retrospective data over 10 years utilizing the Surveillance Project UDC data. She looked at the years 1999 to 2010, and she found that prophylaxis increased during that period of time from 31% to 59% overall, and that bleeding rates were dramatically reduced for all of the patients who were taking prophylaxis. And what we found was that target joint bleeding decreased more with prophylaxis than in those patients who were taking on-demand therapy. So, who should receive continuous prophylaxis? That's where I'm going to turn this over to Dr. Kempton so that she can work on her portion of the talk.
Great. Thanks, Jim. That's a great introduction. So we've talked a lot about what are the benefits of prophylaxis. And when I say continuous prophylaxis here and for the adult population, we're often talking about that secondary or tertiary prophylaxis, often tertiary where there's already joint disease. The MASEC committee with the NHS has recommended that the benefits of prophylaxis, that prophylaxis is begun at a young age in persons with hemophilia A and B, and they recommend that prophylaxis be considered as optimal therapy for all individuals with severe hemophilia A and B. With that in mind, I think who will benefit? Well, in my practice, it's not just patients with severe hemophilia. I try to look at more at the degree of bleeding, and in some patients with moderate hemophilia have sufficient bleeding that prophylaxis is warranted to improve their joint health and function. I start to think about it when patients have had really more than 2 or 3 joint bleeds per year. And this may seem like a low number, but even this number is going to be contributing to joint damage and dysfunction over time. Definitely want to be thinking about it when there's a target joint, which we define as 3 joint bleeds really in the same joint. So 3 bleeds in the same joint in a 6-month period. That's really a bad sign that that joint is going to have be damaged significantly and have problems in the future. Additionally, if a patient has had a limb or life-threatening bleed, even in the absence of significant joint bleeding, I think about wanting to prevent that from happening again, and prophylaxis is the way to do that. Thinking now on the flip side of who could pass on it, maybe who doesn't need it. Even a patient with severe hemophilia may do okay without prophylaxis. There are patients that do have infrequent bleeding despite having severe hemophilia and don't need prophylaxis. Additionally, those who maybe only are having their joint bleeding or muscle bleeding with clearly identifiable trauma or activity, in which case we can take a strategy of targeted prophylaxis or that intermittent prophylaxis where you treat before that event or activity, where you know every time I go out and I play soccer, I get a bleed. Well, if we just treated before soccer and avoided those bleeds, then we would not have a problems with joint bleeding, and we'd be able to preserve joint function that way. So those are the kinds of situations where a targeted strategy may be adequate and continuous prophylaxis is not needed. So once we've decided to do prophylaxis, again, it's often a decision between the patient and the provider. But how is it done? Well, the first sort of choice is often the product to be used. And once you're starting to use prophylaxis, we start to think more about the extended half-life products. And I highlight factor VIII here a little bit more, the factor VIII products, just because I think there's a lot more confusion around what exactly is considered an extended half-life product or not. A lot of products I think are starting to say that they have a longer half-life, but they weren't really designed that way. And in comparison to a standard product, their half-lives and pharmacokinetics are not particularly different. So I'm going to consider that the extended half-life products for factor VIII are a lactate and a dynavate. And these have been studied and have been demonstrated to have sufficient efficacy with a twice-weekly dosing strategy, which for a lot of patients is ideal, is a nice benefit to be able to decrease dosing from 3 times to 2 times a week. Now, in factor IX and hemophilia B, Idelvion and Alprolix are also long-acting options that are available, and those can allow once weekly in Alprolix. Some patients may even be able to get to every 10 days, or with Idelvion can be up to every 2-week dosing. So those are really, particularly with the long-acting factor IX products, are ideal for prophylaxis. Now, although the factor VIII, alactate, and adinovate were targeted for twice a week or every 4-day dosing, there are some patients that can use standard factor products with a twice-weekly dosing strategy. It really depends on the pharmacokinetics, which we're going to be talking about more in just a little bit. So a lot of this is an individualization, and it takes conversations between the patient and the treatment team. Additionally, even with the use of products that are truly designed as extended half-life products, not everybody is going to have a meaningful prolongation with the extended half-life products. So even with factor VIII, alactate, or adinovate, not everybody's going to be a good candidate to be dosing twice a week. So what are the goals of therapy? I'd say the primary goal is really the prevention of bleeding, and all else is going to stream down from that. And I really want to see an improvement in the number of joint bleeds per year. And like Jim said, this is a conversation between the patient and the treatment team as well. I'm counseling folks, though, that we want to see definitely less than 4 joint bleeds per year. And if we're seeing more than that, I want to start working on some strategies to get as close as I can to a no joint bleed state. I also want to see resolution of those target joints. There's a single joint that's having 3 or more bleeds over a 6-month time period. I really am going to pay attention to that joint and see if I can get it to a 0 bleed state. One of the challenges with this, though, when we're dealing with tertiary prophylaxis, is that typically these joints already have a lot of arthritic changes and pain as a result. So it may be difficult to distinguish what is a bleed from what is pain, arthritis pain. And both patients and healthcare staff can get it wrong. We sometimes think there are certain characteristics that may be more likely to be associated with arthritis versus a bleed. And these can be guides, but it is a challenge. And sorting it out, one requires an open mind to the fact that pain may be more arthritis than a bleed. I think this is particularly difficult for our our young adult patients where they maybe aren't really aware yet that they have arthritis, and pain in the past has always been a bleed. So this is a shift for them to recognize that their pain is now as a result of arthritis. Imaging, particularly ultrasound, may be useful, or MRI may be useful to help identify a joint as to whether there's active bleeding or arthritis as the culprit for their pain and their symptoms. Additionally, trial and error may take a little bit of time with changes to the prophylaxis regimen to see if bleeding can be suppressed or not. And pharmacokinetic testing can help us guide us whether we're on the right track with our dosing strategy. Now, another kind of concept to think about is when we're really focused, as I said, as our primary goal on the annual joint bleeding rate, which I kind of think of as the tip of the iceberg. So it's what we see out here. But there's growing concern that there may be some of the iceberg that's submerged under the water that we don't see as much. And this is what we'd call subclinical joint bleeding. And I still put a question mark here because I don't think this is very well characterized to know just how big this iceberg is under here. Maybe it's this line really should be down here rather than up here, and that it's not as big of a problem. We've been suspicious of this based on the joint outcome study that Jim mentioned that Marilyn Mako Johnson did, where a number of the young kids who never reported a joint bleed did have changes on their MRI that suggested that they had bleeding that they did not recognize. So this is kind of where the concept of subclinical bleeding came from. And I think it's going to take a lot more work to understand how frequently we see this, how do we identify it, what are the consequences. And as we get better with our imaging with ultrasound or MRI, I think we'll be having more discussions on this. This is something just to kind of keep in mind, that when your physical therapist or your treatment teams want to be evaluating your joints, they're going to be considering, are they seeing joint changes progressing despite maybe good suppression of bleeding on prophylaxis. Some of the other goals of therapy that we look at and want to consider when using prophylaxis and maybe making adjustments to achieve them, even if we're having good bleed suppression, or maybe we're not having as great bleed suppression but maybe getting some of these other important goals. And that's increasing the capacity for activity without bleeding. We all want to be out being active. It's good for our muscles, it's good for our brains, and be out in the community. So we want to do that without inducing bleeding. Additionally, folks with pain from their arthritis, it may reduce chronic pain. And it'll definitely, as there's less acute bleeding, there'll be less frequent acute pain that comes in the setting of bleeding. So it's really an integral part of a pain treatment strategy, prophylaxis is. It's going to lead to fewer missed days of school and work if those are occurring because of bleeding. And over the long term, it's going to be preserving joint function. So these are all the reasons to be considering prophylaxis and potentially making adjustments if we're not reaching these goals. Now, how do we make those adjustments and think about what are we doing to get to where we want to go with our prophylaxis? And this is a little similar to the other triangle and the 3 points that Jim showed you earlier. But in the center is our goal. Our primary goal is to keep our annual joint bleeding rate low. And the things that are going to be contributing to this rate are our activity level. The higher the activity, the more likely of trauma on the joint, the more likely we're going to be potentially having a joint bleed. And that doesn't mean we don't want to not be active. It means we need to take that into consideration as to how we're going to be tailoring our prophylaxis. The pharmacokinetics is another aspect here, and it's not only the pharmacokinetics of the factor product that is prescribed, but also the individual's pharmacokinetics. As I'll show you in a minute, there's a lot of variation between individuals. Lastly, the joint status itself is something that we need to take into consideration with respect to how we're going to approach our prophylaxis. I'm going to talk first in more detail about pharmacokinetics. This is probably can be the more difficult of the concepts. So pharmacokinetics is the study of how a drug is distributed and eliminated from the body. And this is a curve here of factor 8 that you get a rise pretty immediately after the end of the infusion. Within 15 minutes, you'll have reached your peak. There's a rapid redistribution, so a more sharp slope, and then a slow decay over time, which is the second phase and the terminal elimination. And it comes down here to a trough, and if you were to give another infusion, if you were doing every other day prophylaxis, this is the day you would do your infusion, and this level here would be called your trough. I'm sorry, I'm not using my pointer. Level here would be called your trough. So we start here with our peak, our decay to our terminal half-life, and then our trough. The whole area under here in blue is called the AUC, the area under the curve, and which is the total exposure to the factor. And a lot of these things they're linked. If you have a higher peak, you're going to have a higher AUC. A longer half-life would be a longer time before you get to a set trough. And these are the parameters that are typically measured with the peak, the trough, and the half-life. So as Jim had mentioned before and shown this graph here on the right, that there's a tight link between the number of bleeds that occur and the factor VIII that's in circulation. This graph here on the left is actually not patients that are on prophylaxis, but just patients from severe hemophilia with a factor VIII level less than 1%. In between these bars of 1 to 5 would be those with moderate hemophilia, and those above 5 with mild hemophilia. And this was from a cohort in Sweden. And as you can see, as the factor VIII level moves from 1 to 5 and higher, the number of joint bleeds decreases. And so for some patients, 1% may be sufficient. For others, it may be closer to 5% factor VIII activity to lead to an adequate reduction in joint bleeding. And this graph here on the right showing the time the factor levels below 1% increases is associated with an increase in the joint bleed rate. So this is where the idea of your trough level, again, being 1%, the more time you spend past that 1% line, the more likely you're going to have a bleed. In order to estimate, though, how long you need to have, how frequently you need to dose your factor is going to depend on your half-life. And that the longer the half-life, the more time before you get to whatever trough it is that you need. And that's your kind of strategy is going to stem off a lot about your half-life. And even for a single product, there can be a big variation in half-life. This is one example here of a standard factor VIII product that had a median half-life of 11.1 hours. So that means that half of the cohort had a half-life that was longer than 11.1 hours, and half of the cohort had a half-life that was shorter than 11.1 hours. And 10% of folks had a half-life that was as long as 15.4 hours or longer, and 10% had one that was shorter than 8.8 hours. So you can see there's even a twofold difference here in just individuals with a standard product. Whereas with our extended, and in comparison and as a reference point, the extended half-life products have about a 40 to 50% longer half-life in comparison. So we see even really greater inter-individual variation than we see inter-product variation. And so that's why your treatment team, when they're working to get to a set goal for you, may need to take into account your own half-life in order to get to where you want to be with your prophylaxis. So said again, knowing your personal pharmacokinetics may help your doctor tailor your factor regimen. And measuring, identifying the half-life, your half-life will require multiple measurements over a several-day period. And then from those measurements, some calculations are done and the half-life determined. A little more straightforward and sort of down and dirty approach would just be measuring the trough level with the idea if you're above a trough level, if you never go below that set level, then you should be safe, whether it's above your trough level is 1%, or if you're a more active person, you may need to be up at 5 or 10% accordingly. And that can be done, the trough level would be done just once prior to your planned infusion time, whatever your standard interval is, whether it's 3, 4, or 5 days between your factor infusion products. So now the activity level may influence in particular really what trough you need. How high does the factor 8 level or 9 level need to be for you to be able to go out and do your activities? Or it may also influence the timing, and one strategy would be to do your most intense activities at the times that you do your infusions, that you get your peak infusion. You do your infusion, you get your peak, and that's when you're going to be doing your most intense activities. And you avoid those intense activities during those trough periods. And this will work if one's activities are pretty intermittent. If one is doing more intense activity daily, then that's where you may need to consider having a trough level that's high enough that supports the activity that you want to do. Lastly, as I mentioned, joint status can influence how you're going to deliver the prophylaxis. And some of this is related to those target joints or joints that have had a fair amount of bleeding, even if they're not technically a target joint, but there may be synovial hypertrophy within the joint space, and this joint may be sort of boggy or kind of squishy. And in this squishy synovium, there's blood vessels that are more prone to bleeding. So even at it may take more factor, a higher trough level, more intense treatment in order to get those blood vessels to not bleed. And over time, the synovium will recede, and then there may be able to back off on the prophylaxis at that time. So with that, I'll turn it back over to Jim, who's going to talk more about the barriers and things to consider when doing prophylaxis.
Thanks, Dr. Kempton. So thank you, Dr. Kempton. At this point, we are going to go into some of the barriers and challenges associated with prophylaxis. And when you think about the whole concept of prophylaxis, one of the things that patients are most concerned about is when they have poor venous access, how will they be able to do it? And some patients accomplish that using central venous access devices. And with those, patients really need to be aware of subtle changes in their clinical status that might be a sign of sepsis that's occurring. So for instance, if patients have fevers, if when they go to infuse their product, they get either chills or have some shaking that's associated with the infusion, those are signs that sepsis might occur. And at the site itself, you really need to make sure that you're paying attention to make sure that the port area, or if it's Broviac, that the site itself doesn't have any redness, any swelling, any kind of drainage associated with it. Again, signs that infection might be occurring. This can be a demanding regimen for some families, especially if you're having to do it frequently throughout the week, depending on if you stay with a traditional half-life product versus an extended half-life product. We know that adherence challenges occur, and we'll talk about those in greater detail in a little bit. Cost, of course, increases. And as patients get more and more in tune with their prophylaxis, what happens is you may have this decreased ability to understand or recognize that you're having a joint bleed. So some of the information that Dr. Kempton was saying about pain, patients are having to determine, oh, is this arthritic because I had joint damage to begin with, or am I really having a bleed? And depending on whether or not the individual makes the correct decision, there may be a delay in appropriate treatment if bleeding is actually present. So as far as adherence and prophylaxis, we know that adherence itself is the extent to which patients take their medications as prescribed by healthcare providers, but the caveat here is that this is a plan that's been developed in correlation with the patient and the physician. So they both have input into the actual plan. So it makes it a little bit more understanding when an individual has had the opportunity to be a part of the plan decided upon as to whether or not they're adhering to their regimen. We know that the World Health Organization has said that rates of non-adherence with medications can vary anywhere from 15 to 93%, and the average estimate is around 50%. Adherence to prophylaxis is great for individuals at making sure that success is maintained. It's most effective if your factor levels are continuously above the target trough level that Dr. Kempton mentioned, and we know that once you start missing or skipping the doses and you spend time at that less than 1% range, the graphs have already shown you that bleeding risk increases. And a previous study by Dr. Thornburg and others showed that physicians were reluctant if they felt that the patient might be non-adherent to the regimen that's prescribed. There are other barriers and motivators to adherence. It's interesting that for both the motivators and the barriers, age falls into that scenario. And we'll see that in a little bit, but essentially the motivator as far as age are the very young and those who start to become 30-ish years of age or older. And under the barriers, we see that adherence tends to drop off in teens and young adults. Some of the other motivators to adherence would be the ability to recognize symptoms, a belief that the prophylaxis is necessary and is going to work, and also, interestingly enough, Dr. Tran has shown that the relationship with the healthcare provider, whether it's a positive, trusting relationship, would increase adherence as well. And in the barriers, we know that infrequent or absent symptoms make it difficult for patients to adhere. So if I'm not feeling any bleeding or anything, I may say, I can skip another day here because I really don't feel as if anything's going on. Depression and other considerations from an emotional standpoint can have a barrier to adherence. It's a time-consuming process. The cost itself, some patients may say that that's too much for them to consider, and of course venous access, which we talked about earlier. So as far as adherence to therapy is concerned, we know that it decreases during teen and young adult years, and unfortunately bleeding increases and quality of life decreases when patients opt to drop prophylaxis and move back to an on-demand approach to their treatment. Several studies looking at nursing perceptions of adherence, looking at 147 hemophilia treatment centers around the world, looked at high or very high adherence to prophylaxis in age groups, and you'll see that, as I said before, in the younger cohort, the 0 to 12-year-olds, adherence was rated as high or very high in 90% of that age group. And we start to see a drop-off so that the teen years between 13 to 18, when teenagers start to take care of themselves, we see adherence drop to around 54%. In the young adults who are off to college, on their own, starting their careers, we see that drop a little further to 36%. And then once patients have been established at their jobs, really get an understanding of what's necessary, we notice that adherence jumps back up once they hit about 28 years of age. There was another study that also looked at the impact of the treatment regimen on adherence. And the study looked at patients who were 13 to 25 years of age. And the patients who fell into the 18 to 25 year age group range, they had 6.2 times more likely to be non-adherent than the younger cohort did in that study. Some of the other considerations when you're doing prophylaxis is, of course, this concept of treatment. We would tell you that treating in the morning is best for factor coverage because that's when you're going to be awake and that's when you have the most coverage for activities and any kind of sort of sports that you may be playing. You want to make sure that your coverage is at its best. So treating at night before you go to bed, although some patients tend to do that, you'll notice that the coverage is highest when they're asleep and less active, and we really want to make sure that their coverage is best during the time when they're most active. Keeping track of infusions, any type of infusions, your prophylaxis and your bleeding episodes is extremely important. And as HTCs, we'll take anything that you provide us. Calendars, if you happen to do diaries, either paper or electronic ones, we would be happy to take those, and we're even happy to take factor labels that have been placed onto a plain piece of paper that have dates written on them so that we can decide, what has been working, what may not be working, because we try to correlate breakthrough bleeding with prophylaxis regimens to determine if changes need to be made to the therapy. One of the biggest things to make sure you're doing is to avoid being without any factor whatsoever. So it's great if you can develop sort of this inventory process that you keep track of what's happening at home, and you're working with your home care provider as well, so that they're calling you on a regular basis to make sure that you have adequate supply at home and you never run out. Setting up infusion reminders, you can do those on your mobile devices now. It's a great piece of technology that I'm so glad has been helpful in our teenage population. They've used that in order to say, if I'm on every 10 days, sometimes not easy to remember that, but if I set that 10th day into my phone, it will send me a reminder to do my infusion. It's great if you can establish a routine. Routines are perfect for patients in the sense that you fall into this scenario where when you wake up and it's your day to do your prophylaxis, you've already got stuff set up, set out, and you're ready to go. And then lastly, we want to make sure that if you start to run into any problems that you alert us so that we can decide if there's something going on from an activity level, if there's been further deterioration of joints, or any other concerns that we can work with you as an individual in order to make prophylaxis a little bit more seamless for you. So in summary, a few things that we should remember is that bleeding in hemophilia obviously has a major impact on joint health, that Dr. Kempton has shown the number of benefits to continuous prophylaxis even in the adult population in patients who have joint problems already. Several approaches exist in order to do prophylaxis, and a number of products are available to help us accomplish prophylaxis depending on what's decided between the HTC and the patient. And lastly, you may need to work with your treatment team to individualize the regimen to make sure that it's right for you. Again, Dr. Kempton showed the triangle of all the things that are taken into consideration, and you should really have that very firm discussion with the treatment center team to make sure that all of those points are covered in order for your trough level to be decided on and what product you'll be taking. And then, of course, be mindful to the barriers of prophylaxis that we just mentioned. And if you're running into any concerns, always call the treatment center. And with that, we're open for any questions that you might have.
All right, thank you very much. And ladies and gentlemen, to ask a question via the web presentation, select the chat pod located in the lower left corner of your screen and then type and send your question. If you would like to ask a question live via your phone, press *1 on your telephone keypad. I will announce each caller prior to bringing you into the conference. Please remember, if you have your phone on mute, take it off mute when you are selected to ask your question. Once again, to ask a question via the web presentation, select the chat pod located in the lower left corner of your screen and then type and send your question. And to ask a question live, press *1 on your telephone keypad. All right, and the first question we have is there benefits of prophylaxis for adults whose joints are already damaged?
So this is Christine, I can take that one. I think, yes, there's lots of benefits for patients, for adults with even very severe advanced arthropathy. I think the pain management as a reduction in both chronic pain over time. There's some reductions with the continuous prophylaxis over time, and also the obliteration or avoidance of some of the acute pain that comes with bleeding. I think that's a big impact. A potential benefit would be a greater capacity to engage in activity in our physical therapy that may benefit the joint to maybe rebuild some muscle that has atrophied around a joint, and that muscle then may provide some greater stability. We preventing joint bleeds and improving joint function will over time preserve the joint health. So if you're not having any more bleeds, you're less likely to decline your joints, have the decline in your joint function. I think as Jim mentioned with the Spinart study, that was adult patients with pretty advanced joint disease. They had improvements. Their joint health score is a physical exam score, so they demonstrated improvements in that score, which would be greater range of motion, better muscle strength, less atrophy, and plus the less bleeds, and there were improvements in quality of life. So I think this is really, the Spinart study is very much targeted and generalizable to patients that are adults with already existing joint disease.
All right, great, thank you. The next question we have is, the new non-factor therapies have a higher consistent peaks, and does this mean there are less subclinical joint bleeds on these products?
Do you want to take that one, Dr. Kempton, or do you?
Sure. Yeah, well, I think the non-factor products, so what's currently being investigated would be things like emicizumab, otherwise known as ACE910, and also fitusiran, the antithrombin knockdown. Those are in development. Their kind of concept of their pharmacokinetics are a little different, and there's not really peaks and troughs, but more stable levels, since they have much longer half-lives, and you're not even really reaching a trough level. I think that's an open question. We don't quite even really have a good handle on how to measure subclinical bleeding, so I don't think we would know whether there is or not. I think we have to, even wait to see what the data is as it's to be fully presented regarding even clinical bleeding. I think that's the hope, is that it does, but I don't know that we know nor even could evaluate that issue right now.
All right, and our next question, are you seeing better prophylaxis adherence in adult patients on extended half-life factors?
All right, this is Jim, and I can tell you from my experience, we have seen some increase in adherence in patients, adult patients specifically, who've switched over to prophylaxis. And there was a study, or at least an abstract, that was presented at ASH, I want to say last year or the year before, that looked at adherence in adults with both factor VIII and factor IX deficiency, comparing standard half-life products and extended half-life products. And that initial information, which was I think over a few months' time to a year, that there was some increase in adherence noted for those patients based on some of the pharmacy records, dispensation, and the actual reporting of patients with diaries and things like that.
All right, great, thank you. And it looks like that was our last question. So I would like to thank you both, Dr. Kempton and Jim Munn. And now for our audience, your feedback is critical to us, not only in evaluating this presentation, but in planning of future webinars. Please complete this 5-minute survey appearing on your screen now by clicking on the link. We would like to thank you for attending, and this will conclude the program. Have a great evening.